Thanks everyone for joining. Can you guys hear me? Great. I was getting a little feedback, so I just muted my laptop. Well, thanks for joining us, everyone. We have an exciting list of presenters today. And before we get started, our project manager, Ben Forrest, is kind of going to give everyone an introduction to Sanford Health and Sanford Research. Ben, would you take it away?
Yeah, thanks, Austin. I really appreciate everybody taking the time to join us over the afternoon here just to learn a little bit about CoRDS and some themes about working with researchers and getting a diagnosis in the rare disease space. As Austin said, my name is Ben Forrest. I work here with Sanford Research. This is the first of these webinars that we've done, and we would like to do this again in the future. And so following the webinar, really like to welcome your feedback. Let us know what you thought. Give us ideas on what we can do differently, or certainly if you have any ideas for topics that we can cover in the future, let us know as well. To kick things off, for the folks who are unfamiliar with Sanford Health or with CoRDS, I wanted to give a very, very brief overview of kind of who we are and what we do. So at the highest level, Sanford Health is a large hospital system based in the Dakotas. We cover basically the 5 northern states in the Northern Plains region of the United States. As a part of that, we've got a research arm, and the biomedical research arm is housed in Sioux Falls, South Dakota, at the same building as our corporate headquarters. We have roughly 40 laboratories that focus on basic laboratory science. And of that, we've got about half of them have a project that is devoted to a rare disease. And so we ourselves are, at our most foundational level, rare disease researchers, and we kind of come at this from that angle. In 2010, like I said, coming from that background, we recognized the need and the requirements that the rare disease community has for rare disease registries. Registries are important when you get to a phase where you're ready to launch a clinical trial. And so we launched our CoRDS registry. It stands for the Coordination of Rare Diseases at Sanford. And really what we'd like to do is offer free registries to any foundation or any patient advocacy group that would like one. We provide them totally free of charge. And when you have a researcher or a researcher hears of us and they come and they'd like to access that data, we provide it to them also completely free of charge. And so the CoRDS registry is really our way to interact and reach out into the rare disease community to provide a service to folks that are looking at taking on the task of creating a registry for their community.
Thanks, Ben, for that introduction. A few household or housekeeping items for everyone. Please keep your mics and phones muted, and if you have any questions, enter them in the chat room. If you are in or on the call with a phone, please email us at cords@sanfordresearch.org. We'll do our best to field those questions. And if you're on Twitter, use the hashtag CoRDSChat, and you can tag us at Sanford CoRDS as well. So thanks everyone for joining. Our first presenter is Allison Hutchinson, and she is a genetic counselor with Sanford Genetics. Allison, would you introduce yourself and take it away?
I will. Thank you, Austin, and thank you to the CoRDS team for allowing me to participate, and most of all, thank you to the participants for joining this webinar. I've been asked, my name is Allison Hutchinson, and I'm one of many genetic counselors here at Sanford Health. And I've been asked to talk about how patients and families might prepare for an upcoming visit with a genetic counselor. At the end of my time, I'm hoping to leave time for questions. And if you have stories to share about an experience with a genetic counselor, we definitely entertain those as well. So I'd like to start by setting expectations and describe what does a genetic counseling visit involve. Before I go farther, is everyone seeing my screen okay? Thank you. So at a genetic counseling visit, your genetic counselor may discuss the reason for your referral. Seems like kind of a no-brainer, but it's very important that you and your genetic counselor are on the same page to begin with. A genetic counselor will also explore your family history, and by that I mean the genetic counselor will ask lots and lots and lots of questions. It's not a quiz, but we're trying to get as detailed information as we can. Genetic counselors also provide guidance to help you decide whether genetic testing, is something that you would like to pursue at this time or maybe in the future. And additionally, genetic counselors can provide guidance, emotional support as you decide what you would like to do. In short, genetic counselors ask about your family health history, discuss genetic risks and testing options, and ultimately provide support for you. You should anticipate an informative and thoughtful discussion that will last about 30 minutes to an hour. It should be noted that if you're also being seen by a medical geneticist, that your visit will be longer than that. Not only are you welcome to bring someone with you, whether it's a spouse, family member, partner, or a friend, it's highly encouraged. It's always helpful to have someone else who can listen in, maybe take notes, and ask the questions that you might not think of. So, being prepared will help you get the most out of your genetic counseling visit. So before your visit, be sure to do the following. You can talk to your family members about their medical conditions. And now we very much understand that every family is different, and this might not be something that's an option for you in your state at this time. But as much as possible, start the conversation with close or distant family members about any medical concerns that they might have and how that might relate back to your specific case. If possible, gather your own medical records and any medical records that are available, or maybe other family members who are affected by a genetic condition. And then if possible, and again, we understand that this isn't always a possibility, but if you can, try to bring the results of any genetic test that you yourself have had previously, or maybe a genetic test that other family members have had and have been willing to share with you. A couple other things you can do to prepare for a genetic counseling visit. Before coming to see a genetic counselor, really sit down and think of why you're having this visit, how your story has changed and progressed up to this time, and what you're hoping to get out of the visit. Specifically, you can write a list of questions or concerns that you have. We know that everyone is really busy, and so questions might not pop up in your mind right at the moment that you're being asked them. So if you can come with a list of questions, that's very beneficial. It gives a good starting place. Other logistical things to consider, genetic counseling and genetic testing is often covered by insurance, but every insurance company is different, and I am not an insurance agent or a lawyer, and so some of these things, it's helpful if patients and families can do their best to try to call their insurance company to ask to see if genetic counseling visit is covered and under what circumstances. Those things will be discussed, the cost of genetic testing and insurance company reimbursement if you decide to do genetic testing. That is something that will be discussed in your visit as well. Additionally, as I already mentioned, ask a relative or a spouse or a friend to join you if possible. One last piece of advice is don't wait until the last minute to prepare. Like I said, everyone's lives are very busy, and we realize that this genetic counseling visit is a small piece of your overall day. So start collecting information several weeks before your appointment if possible. So to recap this portion, what you can bring to a genetic counseling visit to be the most prepared is number one, any information about your family history, your family medical history that you know of, any of your own medical records if you're being seen at an outside facility. Bring your questions. And also bring a friend, a spouse, a partner, or a relative. If you've noticed, all of my slides have had a website, a URL down at the bottom. The information that I've presented is from aboutgeneticcounselors.com, and all of this information can be found there for your, if you're interested in looking at it more. When you meet with a genetic counselor, as I said, it's important to bring all the information that you have about your family health history. Some questions that you might be asked include other family members with health conditions, any intellectual disabilities or autism in the family, any birth defects or cancers in the family as well. There's a wide range of conditions that you may or may not be asked about. So this page here specifically from aboutgeneticcounselors.com can give you a great start to your family tree. It includes a lot of first and second degree relatives, and if possible, expand out, like I said, to those nieces and nephews, aunts and uncles. A genetic counselor likes to get a 3-generation family tree. If you find that family members have had medical problems, it might also be helpful to see if there may have been some environmental exposures related to their condition. A genetic counseling visit is the beginning of a conversation, and I really want to leave you with the fact that genetic counselors are happy to see you and your family throughout the entire lifespan. If you're interested in finding a genetic counselor in your area, there's a very easy to remember website, findageneticcounselor.com, and that would be a great place to start. In preparation for this talk, I did have a chance to ask a few of my colleagues what they would say if they were in my shoes and trying to give advice about how to prepare for a genetic counseling visit to patients and families. To end, I'll wrap up with the top 10 list of things to consider when meeting with a genetic counselor, and then I'll leave it open for stories or questions. So number 1, I really want you to know that genetic counseling does not equal genetic testing. Genetic counselors can provide the service of offering genetic testing, but it's not a requirement, and no one's going to make you do anything. It's very much a conversation. To that end, we are not gatekeepers. We definitely counsel people and give them options. We're not going to tell you to have a baby or not. Unfortunately, there's a historical significance of that, and that's definitely not part of our profession today. Most of the time, genetic counselors really do provide patients and families with reassurance, and we try really hard to make things easier to understand. Number 6, most people in most situations feel more positive about their health or that they have more control after meeting with a genetic counselor. Number 7, as I mentioned, genetic counseling is really a journey and a conversation, not just arriving at a diagnosis. We want you to know that genetic counselors are part of an integrated team, and we work very closely with physicians to monitor patients' health. And number 9 and 10, there isn't necessarily a test for everything. Taking that family history, as I've described, is a very powerful tool in our practice. And lastly, the more questions you ask, the more you're going to get out of the appointment. With that, I'll open it up to our moderators. If there are any questions or personal stories related to genetic counseling, I really appreciate this time and would like to thank the group and the participants again for allowing me to be here.
Thanks, Allison. That was a great talk, and I think you provided a lot of good information for patients and families out there. I think a good question to ask, or for you to weigh in on, would be, what is your advice to individuals that might not have a diagnosis yet, or the undiagnosed? Do you ever see individuals like those, or work with individuals like those?
Definitely. And that's all part of the visit. I didn't go into a lot of detail simply because, as our participants know, rare diseases are very unique to the family and can sometimes, that diagnostic odyssey is so much a component of many people's stories. And so to start out, a genetic counselor, when you have a visit, will review your medical records and look for patterns and just read over and pore over any information that the family has provided or that we can find in the medical record. Additionally, the medical geneticist and the genetic counselor work very closely together to develop kind of a game plan going into the visit. During the visit itself, as I mentioned, the genetic counselor will take a family history, and if it's a pediatric case, there'll be, a birth history, a pregnancy history, a developmental history will be taken, any exposures. We kind of try to exhaust all options of anything that could be contributing to the concerns at hand. And then that information the genetic counselor will relay to the medical geneticist typically, and the medical geneticist will then come in and review that and then do a full exam. And so after that, then the team works together, medical geneticists and genetic counselors, to develop what are our next steps. Is there a test that we can offer? Are there other referrals to be placed first? Do we need to gain more information? Are there other records that we didn't get that would be helpful? And so all of those decisions are discussed at that point. And then usually the genetic counselor at Sanford will go back in if there is genetic testing that the team decides to offer, and walks through the informed consent process, talks about some of the insurance, privacy, billing issues that generally arise. And then if the family at that point still decides to pursue genetic testing, sometimes prior authorization is needed and a blood draw is ultimately done. Once those results come back, the genetic counselor and geneticist review them together, and typically here the genetic counselor will call that family and discuss the results and bring them back in for further follow-up, or develop a plan of care with the geneticist at that time. We love when we can find a diagnosis for families, but on the same token, as you mentioned, Austin, that's not always a possibility. And so we definitely have follow-up patients that don't have a diagnosis. We check in with them every year, every 2 years. Sometimes genetic testing is done and it doesn't provide an answer either. And so in those cases as well, sometimes genes and variants get reclassified a few years down the road. So we suggest that patients stay connected with our clinic and check in every 3 to 5 years if they've had genetic testing with no answers, just to see if anything new is available. And then additionally, we can suggest various clinical trials and research endeavors. And I know a couple other of our speakers today will be talking more about that.
Great. I think that's a great segue.
Thank you.
Yeah, so we've got a couple of questions here for you, Allison, from our attendees. There's 2 questions that are somewhat related, and we've got a couple minutes left, so I was wondering if you could weigh in on this. Michael wants to know what folks can do to prepare if they know that they're going to be talking with a genetic counselor about variants of unknown significance. And then Eleonora, would like to know what happens if you receive a diagnosis, but you've never heard of the disease as a genetic counselor.
Right, yeah, those are great questions. Michael, I'll start with yours. Thank you for asking about the bane of our existence, VUSs. In a genetic testing scenario, instead of just having similar to maybe a blood test where you're affected or you're not, or the levels are high or low, genetic testing often comes back with these variants of unknown or uncertain significance, where a change was found, but the lab is, because of the criteria that they use, unable to classify that change as either being pathogenic or being a benign, or some of those normal changes that we see, just normal variation throughout the population. So how can a genetic counselor or a patient prepare for a visit surrounding a VUS? It's definitely part of that larger conversation. So typically I'll say medical management changes aren't made based on a VUS. We don't know if that change is harmful or a normal variant, and so medical management typically does not change, or we don't add additional screening or testing options based on a VUS. As I said, though, variants can be reclassified, and so as more research is done and more patients are seen, more cases are found, and so it's really important to stay connected to the the team that helped you with your original test, or a new team if you happen to move to a different area. But having a continued conversation is important. I think the hope too is that the VUS option wasn't a surprise. The idea of pre-test counseling and talking about the possibilities that could occur with testing, whether results are positive, negative, uncertain, or we even add in the unexpected result where we were finding something that we weren't really looking for. That's all part of that pre-test counseling. So unfortunately, I gave you a hazy answer, and that is indicative of VUSs because they are hazy in our world. Eleanor, can you say your question one more time, or can you reiterate hers?
Yes, so she was wondering what you do as a genetic counselor when a patient is diagnosed with a disease that you've never heard of.
Right, yeah. So that definitely happens, right? There are thousands of genetic conditions, and I, number one, am a new genetic counselor, and so I don't know everything, and I know that very deeply. When a disease or when a condition is a new condition for us, we obviously go to the literature and search PubMed for any case reports that we can find. Another great kind of encyclopedia of genetic conditions, it's not the most up-to-date all the time, but it definitely is comprehensive, is the NCBI gene reviews. And so we'll go there as well. Those two, just a general literature search, and then gene reviews gives us a good place to even find experts in that field. And then we can also reach out to the, like I said, the experts and contact them if possible. The other thing too, it's specifically at Sanford, is that we have weekly case review meetings. And so if a patient is coming in and a genetic counselor is prepping for that patient and they realize, I don't have a lot of experience in this condition, or I've never seen this before, that's definitely a case that will be brought to the larger team of geneticists and genetic counselors, even laboratory and technicians attend that talk and attend that meeting. And so it's definitely a great place to share information. Maybe somebody else is familiar with the condition and can lead the counselor in a positive direction to learn more.
Thanks, Allison. That's some great advice. I think for the sake of time, we'll move on, and I'd like to present our next speaker, Gene Campbell. Gene Campbell is a co-founder of PPALS, the Professional Patient Advocates in Life Sciences, and a external board member of CoRDS, and our very good friend. Please enjoy Gene Campbell's talk. Gene, can you take it away?
Thanks. Thank you, Austin. And I really appreciate, this is my first ever webinar, so please bear with me. And I'm pleased to do it with my friends at Sanford. So thanks, Austin and Alyssa and Ben, for doing this. And I'm pleased to share this panel with Allison and with Jill, because I think the world of Sanford. So you'll probably see this as I start talking. So here I go. I can get this moving. I have been charged with speaking about how to find your community and to drive action. And I'm here today representing Professional Patient Advocates in Life Sciences. PPALS is an easier way to do it. And just quickly, that we are a 501c3 that was established after exhaustive preparation and research and looking for funding and so on and so forth. And I am one of 3 founding board members, along with my colleagues and friends, Jane Gershowitz and Barbara Webbles. And we are committed to helping the function of patient advocacy, which lies in the biotech and pharma industries, and to support this function so that individuals can do their jobs better, and also to help them grow in their careers. And we especially are proud of our ability to help with the encouragement of careers by every year for the past 3 years, going on to 4, is that we work with Stanford in putting on our course of study, which is the Patient Advocate Certificate Training. And you can always contact us for more information about that. And basically, this is our mission And we just want to advance the function of patient advocacy and to serve as a catalyst for positive change by being the face of the company to the community. But today's topic is really more about how do you find your community. And, you know, I always think about this as that no person really is an island, that unless you're a hermit, you're not living totally solo. And that we all belong to some various type of a community, beginning with our family and moving along. And if you see that the word Romeos comes out in full force, it's my favorite acronym for a group of individuals known as retired old men eating out. And it's just one more example of how people find their communities. And why do they belong? It's of various reasons. It could be personal or professional. It's your preference. It's your politics. It's philosophy. It's how you speak. It's how you spend your free time. It's just because, well, I'm joining just because. You have no other great reason. Maybe you feel pressure. Your friends make you join a book club. But maybe most of all, it's all about the passion. So, but what happens when the search for a community is due to a rare disease diagnosis? And having worked in the rare disease space for almost 30 years, and many of that actually interacting with individuals when I was back at NORD about I want to start an organization or I don't know where to go, you always start with the person who perhaps gave you that diagnosis, your healthcare professional, hoping that she or he would be able to make a referral and not end the conversation with, I really don't know what to tell you. Or nowadays, people go to Dr. Google, you know, that leads to rare disease or specific umbrella sites. And that's good. It works out much better. Social media hunt, however you choose, whatever your social media vehicle is of preference. But, you know, and you're hoping that there is something. There's 7,000 rare diseases versus about 3,000 patient advocacy organizations, of which there's duplicity. So that can be a challenge in itself. You do a medical literature search and it makes no sense. It's Greek to you because it's all in this medical jargon. Maybe you figured out to go to some government agencies. You know that about the NIH or the National Institutes of Health, or you know about the FDA, or you're even fortunate to be able to realize you can go on clinicaltrials.gov. There's also media. We're always bombarded. There's print and magazines and talk show. I remember many years ago that I was at a small rare disease group and a woman shared that she found the expert for her son's disease when her mother saw a doctor on a talk show and showed pictures and realized that her grandson looked like the child in the pictures, and found that the KOL, the key opinion leader, was just in the next largest city of the state that she lived. One of my favorite magazine articles is the Sunday New York Times, and twice a month there's a Dr. Sanders puts out a column called Diagnosis and presents a case, and they all figure out, you know, what this disease is. And 9 times out of 10, it's a rare disease. And it's always kind of fascinating to see that kind of situation happen. Maybe if you're outside the US, where are you going to? There are umbrella organizations, your CoRDS, and the Canadian organization CoRD, and the New Zealand organization, and there's now a plethora of organizations in Japan and in China and in India and in South America. They're blossoming all over. And we've come a long way. When I started in the rare disease space back in 1992 at NORD, we were still using snail mail, as they say, and landlines, and faxes were fun. But it has now morphed into more emails and text and paperless communication. So your search takes on so many different avenues that you could walk down. So when that search begins, what are you going to do? So you should, in your research, you have to look for those reliable resources. And you have to make sure that they're coming from a good source and they're not just a fly-by-night kind of place. And if you find an organization, you landscape it, as we say. You take a look at their website. You check out the word on the street. You go to charity watchdogs like GuideStar and BBB Wise Giving and Charity Navigator, who have a plethora of information that can share about an organization. You evaluate it. You look to see what the patient advocacy organization has to offer. Does it have things that you need? Is their social media supportive, and is it open to all opinions? And is it not complacent? It's very easy for social media pages to become very complacent. Is there a way for you to become involved? Can you volunteer? Can you go to a conference? Can you listen to one of their webinars? Can you just call them up and ask them questions? Who's in charge? Who's in charge of these organizations? I find it mind-boggling that in this day and age, I have come across and done landscaping of patient advocacy organizations where nowhere can you find a name or of the board or the medical advisory board. There's no name to the page. And that to me is a red flag. So look to see who's on their board and who's their staff and who's their medical advisory and who volunteers, and really take a look, spend some time on that website. And then I would tell you to test the waters while you're searching for your community, that you want to get in touch with them and talk to them about what their programs and services are. And are they willing to take on volunteers? And are you willing to give of your time? Because that's very precious, as we know. And then when you keep in mind a couple of things, and I share this with industry when I actually give a course during our PPALS course out in Sanford. And so you should all keep in mind that there are guidelines under which a 501c3, a nonprofit, needs to reside. And so the IRS sets those guidelines. So if you're not familiar with them, just be respectful if you think that they're not doing enough. You have to understand the lay of the land in that rare disease community. Sometimes you want to get an understanding of what's going on in that community, what kind of research is being done, does anybody know about the disease? So you do a little bit more homework. Realize that a lot of these patient advocacy organizations have limited abilities. There's no one size fits all. There's all different sizes, from the grassroots, small mom and pop, as they call kind of things, to the mid-range, to the very well-established, well-known patient advocacy organizations. Nobody is going to fit into that one size, and everybody is all different ranges. And in this case, I think that it's important to realize also that some of these patient advocacy groups are all volunteer. People are doing this in addition to having a day job, running a family, doing whatever. This is in addition to. That the organization has some internal guidelines when they're working with various people. And you have to recognize that their time frame and timelines are maybe different than yours, sometimes because it's all volunteer. As with anything, you have to agree to disagree. Nobody is going to be all happy and in concert with each other 24/7. Not happening. So you have to agree to disagree, and not to run at the slightest difference of opinion. It really is to sit down and collaborate and to talk. And it really is important for groups to be transparent and responsible, and you always want to apply some common sense. Because the challenges that face these patient advocacy organizations are off the charts. And some of them could be that you become complacent after a while, or that the social media conversation can be very contentious, and that can make people crazy. The mid-size and small groups have limited resources, as I mentioned, and maybe it's hard for people to volunteer or for the community to figure out how to engage with each other. And the leadership may be overwhelmed or overburdened and just doesn't know what to do or how to take it to the next step. Or maybe they just don't have the experience. When most people start these patient advocacy organizations, they didn't go to school to start a nonprofit. You don't have a degree in this, so you're flying by the seat of your pants. Leadership, you have to make sure that everything is working and is going well. There may be multiple groups for the same cause. That happens. You may seem that these organizations are always asking for money. Well, you know, you always have to figure out how to get other revenue streams, and you have to figure out how to do that. You can't always be going back to the same well. Maybe there's internal constraints with the family, a family obligation, job obligations, or you just are getting tired. And I'm sure that there are many more. And then there's always that great question that we would get and still get to this day is there's nothing out there. So we have to start our own patient group. And my first reaction is always going to be, are you sure? Are you sure you want to do this? You know, have you checked out closely associated or organizations that may be affiliated with your disease? Have you looked at the umbrella groups that are out there? The Canadian CoRD, the Canadian Organization for Rare Disorders, EveryLife, Your Broadest, Genetic Alliance, Global Genes, NORD, amongst many more international ones. Have you checked with them to see what kind of resources that they have that maybe you can hang out there for a little while? Or maybe they can let you know about a group that's already in existence. Maybe before you decide to start a group, you want to join a social media resource and check an online community, whether it's closed or open, or there have been people who start their own personal Facebook page. Or maybe you join an online community like Inspire or Patients Like Me or many other types of online communities that are out there for either general health or rare disease health, where you can at least start to talk to people and sort of get a feel for what's going on. You can always remain unaffiliated or limit your commitment because you choose your level of involvement. It's all up to you. And you can align yourself with just one or as many resources. You do what fits you best. People have turned to writing blogs, and that they kind of create their own fan base, so to speak. I know my sister has a blog and she writes about a bunch of stuff and she has a whole lot of followings. Who knew? You know? And so people share personal insights, and I've seen these pop up, and it does create that personal community. And there are things like The Mighty and Exceptional Parent Magazine and Complex Child and Paperly and Patient Worthy are some of the writing community that I follow and keep in touch because you want to see what's going on. And then after you've figured out all these other avenues, if you still want to start a patient advocacy organization, do not enter it lightly and proceed with caution and with purpose. Because it takes one spark to ignite a bonfire, and I can attest to this because the rare disease community understands the value of being connected to one another. Because it was a grassroots coalition that brought to light the challenges of the rare disease community. When I worked at NORD, I came into the organization not too long after the passage of the Orphan Drug Act and the creation of that umbrella organization that was there to serve as a guiding light. That was the first huge grassroots coalition that gave birth to what we're all living with today. It was organizations that came in around a common cause, something that could happen to them. In NORD's early years, its motto was out of the darkness into the light, and it really did make sense because it was that reliable resource, that unified voice for the rare disease community. And what they found then, and found when I was still working there, and continued on to now, is that key is the communication and collaboration and cooperation. Now, if you want a little entertainment, I'm just going to throw in here that Abby Myers, who was one of that grassroots coalition, starting with her years at Tourette's and then eventually becoming the leader of NORD, wrote a book called Orphan Drugs Global Crusade. You can download it at that website. It's no cost, and you'll be thoroughly entertained, but also get a better understanding of how that one spark ignited the movement to the rare disease community. But if we build it, will they come? And so we have to make sure that you have the cadre of like-minded individuals, that you have people there, and that they are going to be there to commit with you, and that they're there for the long haul. And you're going to start small and build, and you're going to agree to disagree, and you're going to leave your ego at the door because at the end of the day, it's about the community. So, oh, here we go. So you have to investigate what is needed to start a 501 in your state. You have to incorporate, and you file for an IRS determination. And you can look at this. You know, there's ways to do it. There's going to be money involved. There's online resources. And here in Connecticut, there is the Connecticut Association of Nonprofits that gives guidelines. There's one of those organizations in every state. I really want to say that you want to start with a 5-year plan and require updating it every 5 years. And if you're still going to do this, you have to plan for the future at the beginning of the journey. Because if you're going to put this much time and effort into this, you're there for the long haul, and you want to make sure all your blood, sweat, and tears is well worth it. And so besides education and programs and research as the mission and vision for your organization, these are other things that a nonprofit has to think of, from bylaws to board of directors to governance structure, insurance, revenue streams. You have to figure out how to keep the lights on. It maybe you're going to be volunteer run, and when do you move to a paid staff? You have to think about public policy. You have to think about how to help your community, maybe by garnering a natural history or putting together a registry. There's so much to think about. But there's also the rewarding part of it is that you can collaborate and communicate. I don't want to be such a downer, but I think that you want to make sure that you collaborate and communicate with the community you're serving, with the healthcare professionals and researchers, with other medical institutions, with same rare disease patient advocacy organization if there is duplicity. You want to closely align with any and all umbrella organizations because you're all in this fight together. You're going to figure out ways to work with the biotech and pharmaceutical industries. You're going to put policies in place about that. You're going to look at other potential funders outside of your community, and you want to educate the general public because you might want to expand your board and you want other people to get on there. And you want to have a healthy relationship with the media. So when you have core programs, you will be able to assist with driving action. Once you have yourselves set up and running like clockwork, then you will be able to have a board that is willing to roll up their sleeves, and you have a website that looks responsible and clear to navigate, and you have education on your rare disease that has been medically peer reviewed. You have resources that are pertinent to your community. You have a database of members and supporters for various contacts. And I am going to put a plug in here for CoRDS registry. I think that, as Ben shared with you earlier, the price is right on this, and you're going to get good value for the time that you put into creating a CoRDS registry, because it's good for the rare disease, for the community, for the research community, and for you and your organization. So please, please, please consider that. You are going to be able to help with public policy awareness, and you're going to be able to network with everybody else for collaboration. It's just don't talk about collaboration, it has to do it. And hang on just a minute, I'm getting a little pop-up here. And you have to keep apprised of what's going on around you. You just can't live in a cocoon as an organization. You have to be able to be out there and know what is out there so you know what to pass on to your patient community. Here we go. Trying to get to my next slide. I don't know if it's working. Here we go. Here are just some resources for anyone thinking about this nonprofit kind of world to go and how to do it. This is pretty standard. And that's it. That's all I got.
Thanks, Jean. That was a great talk. We've only got a couple minutes, or like 1 minute, so I pulled up a poll. You said you were interested in learning on who's joining the talk today. So if any of you are just listening but at your computers, the panelists, we can collect what type of participant you are. So we'll give everyone just 1 more minute to select what type of attendee they are. Jean, it looks like about half of everyone is a patient. Another third are family members, and then we got a good 20% that are advocates. I'd encourage those advocates to contact us at CoRDS, and we collaborate with advocates quite a bit. So thanks everyone for participating in that poll. Our next and final speaker is Dr. Weimer, who is our Senior Director of Therapeutic Development at Sanford Research and also happens to be the Principal Investigator of CoRDS. Jill, would you take it from here?
Yes, can you guys hear me okay?
Loud and clear.
Okay, perfect. Let me just share my slides. So I think just springboarding off of the great information that Jean and Allison just provided us, sort of in one of Jean's last comments, she talked about sort of how building this collaborative team. And so what the CoRDS team asked me to speak to you today about is how you actually engage scientists as a part of this, because I am a scientist. I know that we can come off as intimidating. Typically, we are not really intimidating people. We actually probably lack many social skills, and that's what's perceived as intimidating. But I want to just kind of talk through this concept of how you would engage a scientist, and you can engage them at many different levels to talk about your rare disease, sort of what's going on in the field, help inform and educate you, or possibly even partnering with to do research. So I just want to kind of highlight this slide. I don't have to explain to this audience what a rare disease is, but Ben mentioned in his opening comments that Sanford Research has really become sort of a mecca for rare disease research scientists. We have over 35 scientists, and a bulk of those folks all have rare disease related projects. So in addition to CoRDS, we have a lot of basic and translational and clinical research that's going on. So one of my roles here at Sanford is actually helping to facilitate those relationships in our rare disease space. So helping our basic scientists to identify external partners that they want to work with, and sometimes these come in the form of other academic partners, they come in the form of advocacy groups, and they come in the form of pharmaceutical and drug companies as well. So just really kind of how do you build that collaborative team and make sure that everybody's getting what they need to out of it, and that at the end of the day that collaboration is synergistic. And I want to kind of just introduce you guys to one model when you think about, whether you're building a foundation, you're working with a foundation, you're kind of out there on your own. I had the pleasure of starting to work on a research program about 3 years ago with the Children's Tumor Foundation, which is predominantly focused on research and patient advocacy and patient support for neurofibromatosis 1, 2, and schwannomatosis. And we had partnered with them. We actually developed a pig model for neurofibromatosis 1, and we received funding from them. And they have a very unique way of approaching science and sort of the partner relationship between their foundation, the patients, and the research scientists. And they call it synodose. And so the concept is through this research program, you're working to achieve synodose. And synodose is a fusion of the Greek word syn and odos, meaning that combine together to mean the word working down a common path. And I think in the rare disease space, many of us as scientists, as clinicians, and you as patients and advocates, we don't have the luxury of competing. It would be completely different if we were working maybe in the Alzheimer's space and there's hundreds and hundreds of labs that are working on Alzheimer's disease, and there's quite a bit of funding both at the federal and private level that go towards Alzheimer's research. But in the rare disease space, you often may only have one scientist working on that disease. One of the projects that I work on in our translational space is on CLN6 Batten disease. And about 3 or 4 years ago, I started working with a family foundation based out of California. And the reason they reached out to me and I became sort of their central hub in their wheel of scientists is because I was the only scientist in the United States at the time that was working on CLN6 Batten disease. So they were able to surround me with some absolutely phenomenal scientists, but really we focused on sort of breaking down those silos so that we could actually take what the patients were saying, what we were seeing in the patients, formulate some basic research, do some drug discovery and drug development, and move that into clinical research so that we could get clinical trials going. So within the Synodose model that the CTF group had developed, each team of scientists is supported by a clinician. So we're always connected and grounded to what we're seeing in the actual patients and what the clinicians are seeing in the patients. But there's also always a patient or a patient advocate that's associated with the team. So anytime we have team meetings for our NF program, there's actually a mom of an NF1 patient who participates in those meetings. There are stipulations that these multidisciplinary teams can't compete with one another. So in our instance, when they received our grant application, they had received a similar Synodose application from another research team who would essentially, in the scientific world, be viewed as our arch nemesis. They were working on something very, very similar. And one of the requirements that the Children's Tumor Foundation was that we had to work together as one multidisciplinary team. Scientists also, if any of your groups have funded research, we're protective of our data because sort of our achievement and success is predicated on our publishing our work, showing it to the scientific community, and really building upon those findings. And so scientists often can be protective of their data, but many scientists take that too far. And they don't share data that needs to be out in the community. And one of the things that the CTF said was that they were seeing applications for the same project or the same sort of project year after year. And these were projects that they had funded and they had failed. And because scientists weren't sharing the data, in particular because scientists tend not to share negative data, there was no way for the rest of the scientific community to know that those experiments had already been done and not worked. And so they really wanted to kind of get those questions out there, that data out there. So they also have a stipulation that your research funding is tied to a progress report. And that progress report has essentially an embargo on it. It has a 1-year embargo. And after that period, they will actually make your data publicly available to the rest of the community. So then it forces you to make sure that you stay on task, that you're actually delivering on what you promised that patient organization that you would do. So this is a model that I have now applied to multiple different collaborative programs. And because of that, I feel like we're actually able to do smarter science. We're always informed by the patients, and we're moving things much faster towards actual treatments for the patients than we were before. And I also kind of just stepping back one step, I want to put up the definition of collaboration. And so the definition of collaboration is the action of working with someone to produce or create something. And so you're working together as a partnership. You probably both, whether it's the patient, the advocate, the scientist, the clinician, you probably each have an individual reason for why you went into this, but you're working together towards one common goal. In our case, it's typically a treatment for rare diseases or even just understanding the basic biology of those rare diseases. But I like to remind people that collaboration has a second meaning. A traitorous cooperation with the enemy. And sometimes I think we get into the spot where science becomes so competitive that it does become almost a cooperation with the enemy, and that we lose sight that the reason that we're in this is to actually help the rare disease patients. And so I put this up there to say that my team definitely stands by the first definition of what a collaboration should be and what we try to strive for. And then as scientists too, we are often seeking the blessing and approval of our peers, that the science that we're doing is meaningful and that we're helping to solve real world problems. And a lot of our funding comes through the federal government, through the National Institutes of Health. And I put this slide up here simply to say that the National Institutes of Health are really starting to learn from some of the trailblazers in disease foundations that have set up models similar to the Children's Tumor Foundation, where there are these tight metrics and milestones for success. And so the NIH has actually also started to really push and promote this concept of team science. And these graphs, I don't expect you to really take anything away from these, but in a recent report from the NIH, they went back for the last 2 decades and looked at their funding that had come in as a part of team science versus NIH grants that were a single investigator. And they found that those that were the grants that they had funded that were composed of a team of a multidisciplinary team of scientists were much more successful, higher, more meaningful publications. They were getting more meaningful outcomes from those works. And so even the NIH is moving towards this concept of that we shouldn't be siloed, we shouldn't be trying to tackle these problems on our own, and that we're going to move faster and do better if we actually work together. So my research is focused on 2 key areas. I mentioned the neurofibromatosis work, but we also work on Batten disease. And there may be some of the family members that are part of the Batten disease community. This is a rare neuropediatric disease. And it's actually about 13 different diseases, 13 to 14 different diseases, that each form of the disease is results from a mutation in a different gene. But collectively, Batten disease, as the family names, the most common neurodegenerative pediatric disorder worldwide. And I'll just tell you the story of one of the foundations that I work with to give you sort of a sense of the disease progression in these kiddos. So the kids for CLN6, which is sort of our primary wheelhouse, the kids are born seemingly normal. Usually around their 3rd to 4th birthday, the parents start to realize that they're having some language deficits issues. They're forgetting words and struggling with words and stringing sentences together seemingly almost overnight. They start to develop motor abnormalities that over the course of the next year will rapidly decline. They'll become wheelchair bound. Usually in the later stages of the disease, they'll develop seizures. They'll ultimately go blind. And these poor kids usually succumb to the disease around their 10th to 12th birthday. So about 2.5, 3 years ago, I mentioned that we partnered up with a California-based foundation called the Charlotte and Gwyneth Gray Foundation. And really, they took this multifaceted approach to developing treatments for Batten disease, or also called neuronal ceroid lipofuscinosis, which is a tongue twister. And really, we tackled this from multiple different directions. So as I mentioned, I was the only CLN6 researcher at the time. I was kind of put at the middle of this. And I worked very closely with the family and the scientific advisor for the family to identify leaders in many different translational therapeutic modalities around the world that really probably had never heard of Batten disease at all, but they were able to bring their expertise in treatment and modality to the table. We now have a team of about 10 scientists that work tirelessly and around the clock on developing treatments. The first of the treatments that we developed, a gene therapy for CLN6 Batten disease, we started on the basic research in August of 2015, and we were able to get into a clinical trial in under a year. So there's now, for the first time ever, there's hope for these patients, but the only way that has been possible is through a very, very close collaboration between the family, the patients, the scientists, and the clinicians working together to tackle this. And just in this particular model, in the first year when we were moving at breakneck paces, the scientific team, the research scientists, the scientific advisors, and the families had a weekly call to discuss progress. Even today, we still come together on a quarterly basis. And at that point where we are required to show, here's the productivity that we've had in the last 3 to 4 months. And it really keeps us on task, and it really keeps us moving forward. And it reminds us that we are accountable to the patients at the end of the day, that is, again, like I said, the reason that we're all in this. So what the CoRDS team really asked me to talk about is how you actually foster those relationships. And I threw some things down on here, and I want this to be more sort of a discussion with the team. I know we're running close on time, but I just put some things up here that when you're building a relationship with a scientist to think about. I would, before you reach out to the scientist, ask yourself what it is that you're hoping to get out of that relationship. Maybe you're actually just looking to learn more about the disease. But at the end of the day, whatever it is that you're doing with them should be built on trust and a shared vision. So set aside time to get to know that scientist, whether it's at a conference, whether it's you going to visit their lab, whether it's just spending time on a phone call with them. Tell them a lot about yourself. If you're a parent, tell them about your child that's afflicted with the rare disease. And they'll want to get to know you, but through those conversations, you'll get to know what sort of person they are, and whether they are somebody that you can trust for the long term that you want to work with. Ask them about what the key areas of research are that are going on. Any good scientist is going to talk to you about the best science and not just their science, right? And so that's also going to help in that trust. Are they willing to say, maybe I need to connect you with my colleague who's doing this, because they're probably more of an expert than we are. Don't hesitate to ask them how they might be able to add to how you might be able to help them with their research program. Many of them may say that they're looking for funding to continue their research, but maybe some of them just need access to a DNA sample, or maybe they need to be able to make a cell line. I have a scientist here who he had the exact issue where he just needed access to the patients to be able to do some DNA-based genomic work. He didn't actually need funding for his research. He just needed the resource that the patient themselves brought. The other thing too is to just keep, I think Jean alluded to this, we all get busy. So if somebody doesn't get back to you after the first email, don't hesitate to prompt them again. They're probably not ignoring you. Probably it just slipped their mind. They didn't get to that email, or maybe they're out of the country. And so don't hesitate to follow up with them and just re-prompt them. And then if you do move into the realm of actually funding research, like I said, I really encourage you guys to look at this model that the Children's Tumor Foundation has put together. But no matter how much trust you have with the scientist, don't rely purely on their word. Get a panel of scientists, a scientific advisory board, a clinician to help you look at the science and make sure that there aren't any holes in it. Get a clear plan of how they're going to use those resources, and then really set clear expectations of how they're going to report out to you, how they're going to share that data, and come up with a plan for sort of beyond the scope of that particular project, how they're going to continue to pursue that research. Because sometimes, I've seen time and time again where a foundation will, work around the clock to raise funding for research, and maybe they're able to give a $50,000 research grant. And oftentimes those funds are enough to seed a project. But if the research scientist doesn't have a clear plan how they're going to pursue the research beyond those $50,000, then it kind of ends with that funding stream. So the last thing I'll put up here is I'm always available to answer questions. I work closely with the CoRDS team. So I just wanted to make sure that you guys have my contact information. You can learn more about our research on our Sanford Research webpage, or you can follow us on Facebook, and we try to give updates on sort of our research successes and our interaction with the patients that we serve. But at the end of the day, don't hesitate to reach out to scientists. Like I said, we have a lot of quirky personalities, and I think sometimes you just have to get beyond those quirky personalities.
Thanks, Jill. Looks like we just have one question. Thanks, everyone, for hanging on with us. Ben, you want to take the question away?
Sure. So it looks like we have one question from Anne. Jill, she wants to know if scientists at Sanford use AI-based research tools to, do some more predictive modeling.
Yeah, and some of us have. Some of it, I think it depends on really what the questions that you're asking and the tools that you use. But definitely some of the people who are more in our cancer biology and in our genomics research labs have used some AI work for sort of predictive. We do a lot, even beyond just necessarily AI, like a lot of modeling and a lot of design to understand, in some diseases, there might be 100 different mutations. So how do those different mutations relate to different phenotypes based on the genotype? So most definitely, it's something that we use.
All right. Well, thanks again so much for everybody taking the time out of their day to join us. This is it's been great. From here, we've recorded the webinar. So after this, we're going to find a way to get that shared out online, and we can certainly share links with you. I'd encourage you all to give us your feedback. What did you think of the webinar? What would you like to see in future webinars? You can send those comments or questions to us at CoRDS@sanfordhealth.org. Again, that's simply just CoRDS@sanfordhealth.org. And once we've got everything put together, we'll send out an advertisement. Last thing before we go, I just want to invite you all to, if you are headed to Irvine, California in a couple weeks for Global Genes annual summit, both Austin and I will be there. I'll be giving a talk about registries as part of a panel discussion. Please don't hesitate to get in touch with us or contact us to learn more about CoRDS.
Thanks, everyone, for a very productive webinar. We hope to hear from all of you and do this again. Thanks, Jill. Thanks, Jean. Thanks, Allison. We'll log off now. Send any questions to us. We'll be happy to answer them.
Thank you.